Today I'm going to talk about DiGeorge syndrome. DiGeorge syndrome is a primary immunodeficiency disease resulting from an abnormal formation of chromosome 22 during fetal development. A small portion of chromosome 22 was deleted during fetal development, causing abnormalities and learning disabilities in the infant. As you can see on this picture, there's your set of chromosomes. On the left-hand side is the deleted region, and on the right side is a normal chromosome. The inheritance pattern. DiGeorge syndrome is considered an autosomal dominant because a deletion in one copy of the chromosome 22 in each cell is sufficient to cause the condition. Most cells are not inherited. In fact, the deletion occurs most often as a random event in the early fetal development. Those affected typically have no history of the disorder in their family, though they can pass the condition to their children. Clinical manifestations. Not all patients diagnosed with DiGeorge syndrome present the same way. Some have cardiac problems, some don't. Some may have facial abnormalities, while others have none. This is called phenotypic variability. Patients may present with one, some, or all of the following manifestations: cleft palate, poor function of the palate, difficulty swallowing, thymus gland abnormalities, parathyroid abnormalities, which results in hypocalcemia. Diagnosis. A diagnosis of DiGeorge syndrome is based primarily on a lab test that can detect a deletion in chromosome 22. The doctor will likely order the test if the child presents with a combination of medical problems or conditions suggesting DiGeorge syndrome, or a heart defect because certain heart defects are commonly associated with the disorder. Outcomes, expectations, duration, and patient education. Patients diagnosed with DiGeorge syndrome may have different outcomes, expectations, depending on the affected organ system. The most determining factor is early diagnosis, correcting any heart defects, and management of immunodeficiency problems. There is no cure. However, with proper treatment, the infant mortality rate is estimated relatively low at 4%. Patient education. Taking calcium supplements, frequently washing hands to decrease infection rate, and using a multidisciplinary team, including an immunologist, are also factors that determine the patient's outcome. The estimated incidence with DiGeorge syndrome is 1 in 4,000 births, and most commonly in infants. Treatment. Pharmacologic is calcium supplements and vitamin D supplements. Medical, corrective heart surgery, thymus transplant, stem cell transplant, or surgery to repair any palate abnormalities. And non-pharmacologic, you could do speech therapy, developmental therapy, or maternal and child bonding. Highest priority nursing diagnosis is decreased cardiac output related to altered afterload as manifested by abnormal skin color or cyanosis. Nursing interventions would be place the client in semi-Fowler's or high Fowler's position with the legs down, which decreases the work of breathing and may not compromise cardiac output. You could also provide restful environment by minimizing controllable stressors and unnecessary disturbances, which also decreases cardiac workload and oxygen demand. Lastly, you could monitor for dyspnea, fatigue, or weakness, which are signs consistent with heart failure. NCLEX question 1. A nurse should anticipate to see what pharmacologic orders in the patient's chart. Select all that apply. A. hormone replacements, B, calcium supplements, C, speech therapy, D, developmental therapy, or E, vitamin D supplements. I'll give you a few seconds to think about this. The correct answer is B and E. Hormone replacements doesn't apply. Correct answer B would be calcium supplements, which are given for hypocalcemia, which is associated with DiGeorge syndrome. C is a non-pharmacological treatment. D, developmental therapy, is also a non-pharmacological treatment. And E, the other correct answer, is vitamin D, which is given because it helps the body absorb the calcium supplements that they are taking for hypocalcemia. NCLEX question 2. DiGeorge syndrome is caused by A, a formation of an extra chromosome during fetal development, B, a microdeletion in chromosome during fetal development, C, taking too many prenatal vitamins during the first 6 weeks of pregnancy, or D, not taking enough prenatal vitamins during the first 6 weeks of pregnancy. I'll give you a few seconds to think about this. The correct answer is B. A microdeletion in a chromosome during fetal development is associated with DiGeorge syndrome. A formation of extra chromosome during fetal development, that's found with Down syndrome, not DiGeorge. C, taking too many prenatal vitamins during the first 6 weeks of pregnancy, does not apply. And D, not taking enough prenatal vitamins during the first weeks of pregnancy, also does not apply. Well, you made it. Thanks for watching.